My topic is about atherectomy device for the Fempop intervention. So this is my disclosure. So you already know that the key point to do the endovascular for the Fempop, first of all, we have to do the vessel preparation before we going to do the finishing definite lesion. That we have a lot of options that the previous speaker already mentioned before. So for atherectomy device is have a role or one of the options, especially for the lesions are very complex or heavy calcification that we use. If we use only the pole bar, sometimes it doesn't work. So this is one of the options that we can use with the heavy calcification. The atherectomy device can, of course, can remove the obstructive material from the vessel lumen and make the luminal gain. Most importantly, besides from the luminal gain is improved vessel compliance that can allow us to use just the low pressure balloon to make the vessel expansion. And then the best thing is it can decrease the chance of the dissection and of course the chance of stenting that we don't want to put the stent in the patient. And in case that we want to use drug technology in heavy calcifications, the best thing of the atherectomy device is can allow the drug to penetrate the wall of the vessel. We have a lot of atherectomy devices in the market right now, as shown on the slide. I will point out some devices. For example, the directional atherectomy device, the Hawk one, is suitable for the eccentric park lesion that have a severe calcification. But the bad thing is have a chance of distal embolization that we don't want to face. For rotational atherectomy device like Jetstream is suitable for the concentric lesion, calcified lesion that you can remove. Other device like orbital CSI, the hybrid Phoenix, do the same. And the last one, the laser, is only one that FDA approved for the ISR device. So when the patient and the lesion selection is one of the more important when we going to use the atherectomy device. Most of the case we have to stay intraluminally, except for the laser. Even in subintimal, maybe you can use it, but otherwise you have to stay intraluminal for use the atherectomy device. And the one of the complications when we use atherectomy device is a distal embolization, especially in the thrombotic lesion, in the ISR or in the CTO lesion, have more chance of distal embolization than just stenosis. During the case, of course, we have to keep heparinization, at least the ACT 250. And to select the distal embolic protection device, it depends on the IFU and the doctor preference. This is just some guideline how to choose the distal embolic protection device. In case that CTO, ISR, thrombus, or single run off, you should use the protective distal embolic protection device. But for the short lesions, maybe you don't need to use it, but of course it depends on the IFU and doctor preference. For the device of the DEP, this is a guideline that for each device, which one is you should use. Most of the case is NAPSIC, or for the Hawk one, maybe you can use a Spider FX. Nowadays, when we compare the atherectomy device with the pole bar or with stent, you can see here the rate of distal embolization and perforation is a bit higher than pole bar. But of course, dissection is less than POBA, and you can see here the rate of stenting is lower than when we use non-atherectomy treated patient. When we look at the 1 year primary patency, it's not different. Even the major amputation is quite low than the POBA, but it's not significant for this is data nowadays. So I will show you some cases that using the atherectomy device in my experience. First case is a female 61-year-old with a gangrene on the left leg. This is her underlying disease. So anticate approach, you can see here is a occlusion of the left SFA. Reconstruction at the distal SFA and only the single AT run off with the disease. This is run off only the AT. So in this case, because even it's not heavy calcification, but we want to avoid stenting in 60 that not old. Okay, we try to stay intraluminally. We start with the V18 and support catheter and check with the IVAS. I always check with the IVAS that my wire is stay intraluminal before using atherectomy device. And of course, in this case, regarding the IFU, they recommend to put the filter. Okay, I put the filter at the lowest of the vessel and start use, in this case, use the jet stream 2.4, 2 rounds of bed down and 2 rounds of blade up. Go down slowly. And this is angiography after the first round and the second round. You can see first and second not quite make difference, but when look at the IVAS, it's the same lesion. You can see here before and after use the bed down and blade up, you can have the luminal grain significantly from the shown on the IVAS. And then I use the POBA as mentioned, but use just nominal balloon to make the vessel not to prevent the dissection, and finishing with drug technology with the DCB in this case. This is and then I go to do the BTK as usual, passing the lesion, and then use the NC balloon for the BTK. This is after the BTK, but actually you don't need to do this because it's already complete the room, but it's just I don't know why. So I passing make the room. I want to open more, but actually it not don't need because this case is already it's small wound and it's already perfused to the wound already. Okay. This is a final angiogram from above. Some dissection, but not for limiting of the Fempop. It's a AT runoff, and this is distal at the foot. And you can see here the flood at the wound. This means it's enough to supply the wound to heal. So for the ISR case, when use of the atherectomy device, even only the laser that approved by FDA to use, but of course in daily practice, I use for the ISR, I also use the atherectomy device, maybe off-label for the ISR. The same procedure, the same step, just passing the lesion with your choice of wire that you usually use, confirm intraluminally by IVAS. Maybe some not maybe have some not thrombus, maybe organized in this case. I put the filter at the lowest end of the vessel, and then start use the atherec. In this case, the same, use the Justin 2.4. Slowly. The one thing of Justin, even the name is atherectomy, but it have some suction power to aspirate some thrombus, but not too much, in just some fresh thrombus. And this after the first round, I do the second round. For the ISR, sometimes I not use the braid up because I afraid that braid to stuck with the stent. After that, I use the POBA and finishing with the DCB. And okay, this is final angiography. And then this is last case. This is a 79-year-old female breast pain. She underwent a previous stenting of the left external iliac artery and common femoral artery 2 years ago, and come with the breast pain because of the disease of the Femorpopliteal and BTK. This is a disease you can see here, very small, and only the perineal runoff supply to the foot. So in this case, because of calcification, we want to use a atherectomy device, cross over from the right side, and in this case we use the OAS still 360. After passing the region check that the wire not subintima, and start to use very slowly. Just show this is the orbital atherectomy device, the stem. And then because of the calcium is more at the distal, at the mid and at the distal at FA, so in this area I go up and down many times. And then this after atherectomy. In this case, I want to show you not only the luminal gain that the atherectomy device can provide us, but for my experience, I think one thing that very important for the benefit for the atherectomy device is vessel compliance. I will show you on the oh, sorry, it doesn't work. Okay, sorry, the video is not run. So what I want to show you on the left side is I was before atherectomy device, and after you can see the compliance is better after we use atherectomy device. So, and then we put the POBA. In this case, the vessel very small, just 5 millimeter. And then this is a final. Oh, in the video, sorry. So, this is the conclusion for the role of the atherectomy device. In case that you don't want to put the stent, for example, the no stent zone, or the young patient, or the lesion that the simple POBA cannot cope with this lesion, for example, heavy calcified lesion or the compact part C and part D lesion. This kind of patient and lesion is maybe considered to use the atherectomy device. That of course nowadays the data show when we use atherectomy device, we can reduce the rate of dissection and the rate of stenting. Even nowadays, it's not proved that the primary patency is better than use the POBA and a stent. Thank you for your attention.
Thank you very much, Professor Wuttichai.